Amin Chenbouli, an interventional cardiologist from Morocco, and I am very pleased and honored to be here in Tunisia to talk about important subjects in interventional cardiology. So my subject is talking about isolated ostial LCX stenosis, and these situations like that is all the time for us are tricky situations and risky situations, because we want to treat an ostial LCX, but we are very afraid to compromise other important arteries such LAD and left main coronary artery. So it's always a tricky situations. We will ask ourselves a lot of questions. Are we gonna only stent the ostium? Are we gonna put a stent across the bifurcation? Maybe you can put just a drug-eluting balloon. Maybe sometimes just medical therapy, why not? But we know that at the point when we start asking a lot of questions, we know that it will be difficult. And if we don't have a systematic approach and a nice strategy, it's the only strategy to success and to have nice results. So I have not much time, so I've set for myself two goals in this presentation, two simple goals. First one is to convince you that LCX is actually an important artery. And the second one is, which I think the most important one, is to say to you that really isolated ostial LCX doesn't really exist. And I have this case that I had last month, and it was about a 62 years old man who presented to our cath lab with a non-ST elevation myocardial infarction with positive troponins. And when doing coronarography, we was in front of this ostial LCX stenosis. And first thing and first fact that we understand that very often these stenosis are eccentric, and this is actually due to the dynamic of flows and the fact that very often the plaque burden spares the carina, and it goes either in the lateral wall or the myocardial wall of the bifurcation. And to convince you that LCX is an important artery, there is a software that actually calculates the relative mass of vessel that draining a territory in the myocardium. And when we are in front of a normal LCX, it's in the very oftentimes draining about 11 to 12% of myocardium. But when we are in front of a dominant LCX, this percentage can rise till 64%, to tell you the importance to treat this artery. And when treating this LCX stenosis, we have to take into consideration physiology. Physiology is important because in these situations we are in front of focal lesions, and the mechanism of drop of pressure in focal lesions is actually turbulence at the entrance of the vessel. And we know from basic physiology that there is a continuous relationship between diameter, mass, and flow. So beyond being an ostial lesion, it is a lesion that supplies a lot of mass, so we will have a greater flow and a greater drop of pressure. So if I ask you what is the classification of Medina here, I think that we will all agree that is a 001 classification, because we see that apparently the ostium of LAD and the left main is healthy vessels, but we must pay attention that is Medina classification is only a angiographic classification, and angiography it's just luminography. We don't see what happens in reality, and there is the importance of intracoronary imaging that tell us what happens in reality. And we know it from many years ago, that with the IVUS, we can understand that she's not only a stenosis in the ostial, but it is more often a disease of the bifurcation, and the plaque burden more often goes from distal left main to goes up from to ostial LAD and ostial LCX. So it's very, very important to take into consideration that we are treating a bifurcation and not only a simple ostial stenosis. And from IVUS, we can understand that only this situation is only happen in 60 to 7%. So we start to treat this bifurcation with putting 2 wires. This is very important. We are in front of left main bifurcation, the most important bifurcation in our body. So it is primordial to put 2 wires to protect the LAD and to have like a rescue if something happens. So we taking into account all these facts, we decided to stand across the bifurcation with a stand that this is to tell you the importance of the jailed wire. It can save our bifurcation, and it can permit us to, like in situation of occlusion of the side branch, to put a small balloon and realizing the rescue balloon jail in technique. So when choosing the stand, we must respect the fractal law and always choose a diameter according to distal vessel. And with this, we must know our stands. We must know the degree of their expansion, and we must choose a stand that can be after optimized to the size of the left main. And we see that if there is no stance that can go from like 3 millimeters to meet the size of a left main that's doing 4 or 5 millimeters. So in this schema, we see that what we see in angiography, what is real anatomy, and what we can have like a strategy. And we see that if we choose to just nail the ostium, we will, in a greater percentage of cases, either be shorter, so we can put our stand in just the plaque burden, or we're gonna be more proximal and we can compromise the flow in the side branch. And that's what we don't want to do, like putting our stand in the middle of a plaque burden, because we know that is a great risk factor of thrombosis and stenosis. So this, I think, in my understanding, the best strategy is to stand across the bifurcation and not only nail the ostium. So we are back in our case. We have put our stand, and we see clearly that we had compromised the flow in the ostium of LAD, and that is because, like in the most cases due to a plaque shift in the LAD, we don't have intracoronary imaging in our lab, so this is what we can say about this. And another thing, that when we want to remove our jailed wire, it is important to pay attention to the fact of pulling back the jailed wire. The guide catheter can go forward, and it can destroy the proximal side of the stand. So what we have done is enlarge the struts from LAD, from left main to LAD, and we see what happens after. The plaque is still there, so we decided to put a second stand going from the left main to the LAD with a kissing balloon, and after we had what we think it's a nice result. So, is there any situations when we can just nail the ostium? In my understanding, there is one situation is when there is a big difference between the size of the distal vessel and the left main, and we cannot put a stent that can go from the diameter of the LCX to the diameter of the left main. And how we can nail the ostium, there is no consensus, but we can find our best working view to just localize the ostium. Some authors suggest rapid pacing to try to stop the heart and not having a moving of the stent, and the use of intracoronary imaging is always helpful in these situations. There's also this technique where we can put a balloon as a marker in the ostial of the LAD, so we can positionate our stent nicely in the ostium of LCX. So with this presentation, I hope that I convince you that imaging is very important in this situation. Physiological assessment is also very important, and that crossover is always the best way to treat these situations. Thank you.